My name's Beth. I work as a neurosurgical nurse practitioner here at JFK at the New Jersey Neuroscience Institute. I'm here to talk to you about palliative care, palliative medicine, and to clear up, just to kind of explain the philosophy of it, clear up some common misconceptions. So, what is palliative care? The idea is what palliation is. It's described as relieving symptoms of a disease or a disorder. So really the focus is understanding symptoms, treating those symptoms in order to have people have a better quality of life. By controlling symptoms, you can help cope with aggressive treatments, getting pain and other symptoms under control, help the person and help the body to better fight the disease that they're up against. There is a study, there's actually more than one study out, but one of the studies found that patients who had a cancer diagnosis, and if they received palliative care services within like 5 weeks of being diagnosed, regardless of whatever the treatment is going to be and whether or not they felt that they could be cured, they were more likely to continue with treatments, able to complete treatments and have a better quality of life while going through those treatments. They felt better, so they did better. People who didn't receive those services didn't do as well. A lot of people, unfortunately, weren't able to complete chemotherapy treatments because they just couldn't tolerate the side effects of the medicine. So it's a team approach. And it's a holistic, synergistic approach to patient care. The team, first and foremost, the team consists of the patient. Patient and their families are actively involved in decisions. They are members of the team. There is free-flowing communication between all members of the team. Consists of medical professionals, not only if you're being treated for cancer, not only an oncologist, but there's a doc or a nurse practitioner, regular nurse, who is going to work as the palliative end of it, and work in conjunction with the other doctors in order to, again, control symptoms. Social work, chaplains for spiritual support, counselors, not only for the patient, but also for the families. People have small children, helping the children to understand and to deal with what's going on in their lives. Nutritionists, a lot of times people have, they have decreased appetite, nausea, anything like that. Nutritionists play an active role. The role of therapists, physical therapists, occupational therapists, speech therapy, even massage therapy and guided imagery. All things that are going to make you feel better and to help to alleviate symptoms. Pharmacists play also a role. We think of medications as a treatment. Sometimes we use medications for their side effects because that's what's going to help to relieve symptoms. So really it's a team approach. In terms of symptoms, what symptoms are treatable? Anything that adversely affects your life is something that can be treated. Big things are pain, getting pain under control, shortness of breath, fatigue, nausea, vomiting, problems with the bowel or the bladder, not being able to sleep, feelings of depression, feelings having coughing, delirium, confusion. All these symptoms that people have are absolutely treatable. So, and the benefits, by controlling symptoms, effective symptom management really can impact somebody's care, and it can actually make people, even if the disease is progressing, it can still help them to be actually more mobile, to function at a better level, and to actually feel like they have a better quality of life, even if their disease is progressing and not getting better. When you're in when symptoms are controlled and you can think a little bit more clearly and you don't have that stress plays a tremendous part on the body. By controlling symptoms, you're more able to keep those goals in line, and you're more able to have those goals still be in line with what your body, your mind, your spirit wants. And also helps in long term how you want to live your life and what decisions coming forward, what's acceptable, what's not acceptable. And again, the main focus is that your treatment decisions and how care is going forward is based on your life, your goals, your values. And it's personal. It's personal to each and every patient. So common myths and misconceptions, not only with the general population, but as I said, with practitioners, medical practitioners, there's still a lot of misunderstanding about what palliative care is and how it can help the patients. So one of the very common is they're going to cut me off, no longer going to receive treatment, they've given up on me, but that's a big fallacy. It's not for when you can't be cured. Most people believe, a lot of people believe that once they introduce palliative care, there's no cure for you, and they just want to make you comfortable. But it can be, palliative medicine is provided while doctors work aggressively to help you and to treat the illness. Misconception is that palliative medicine is, kind of a backseat, low key. It's an aggressive medicine. It's aggressive treatment. When you fix one problem or treat one condition, you can cause other problems. The job of palliative medicine is to figure out what's bothering you and then aggressively treat that, so then therefore you have a better quality of life. And you're better able to deal with your main diagnosis. For people who are terminally ill, I'm going to die, this is it, but fact of the matter is everybody's going to die. We're all going to die someday. So that being said, palliative care is for anybody, any age, any stage of an illness, any illness, whether it is curable, whether it's chronic, whether it's life-threatening. It still is, it's pretty much for everybody. Like I said, it's very prominent also in pediatrics, which people don't think of. But again, the focus is not on death, it's on living. You're not focusing on the way that you're going to die, you're focusing on the way that you're going to live and to have a quality of life. Another misconception is you're going to be drugged out. I'm going to be not aware of my surroundings, I'm going to be confused, I'm going to be like a zombie from all the medications. And fact is that a lot of people, when they have the pain medications, when you're on pain medications and it's adequately controlled, you don't have a problem with thinking. You're not going to be sleeping all the time. If that does arise, that's really not in line with the goals and your quality of life. With what we do is we just redefine, see what's going on, and then fix that so that you're not experiencing those symptoms. Because again, the goal is for that individual to carry on with their daily activities and to be able to still continue to participate in their life. No longer going to be in control. So the focus of palliative care is autonomy. Autonomy for the patient. Autonomy is the duty to respect an individual's thoughts and their actions. You control the situation. You define your goals. Only you, it's personal. So you tell us what is an acceptable quality of life and what is acceptable care. You're treated as a person and you're not treated as an illness. And probably one of the biggest misconceptions is that palliative care and hospice are synonymous, and it's really not. That actually with palliative care, you may recover from an illness, relieving symptoms, pain, anxiety, loss of appetite. If we can relieve those symptoms, you're better able to tolerate medical treatments that are provided for you. And like I said, able to go through those treatments and to complete those treatments. And then people do actually, who do receive palliative care, sometimes do get better. If they don't get better and your treatments are no longer in line with your goals for your quality of life, it is a smooth transition into hospice care if that's what is appropriate at the time. There was a big article in New Jersey, in the New England Journal of Medicine that when people who had a cancer diagnosis If they received palliative medicine services, if palliative care became part of that team within like 5 weeks, people actually lived longer and they had a better quality of life. They were more, their families had a positive experience. And like I said, they lived longer. So again, relieving stress and relieving those symptoms helps the body to carry on. So that being said, I can introduce Patty. I know, I'm sorry. I know, does anybody have any questions on?
I could say I believe it's power of the mind.
Absolutely.
I just know, so I can't remember what it's called. It's it's like a therapy where they actually, they're going to get like the massage and then it's going, I forget what it's called.
Like a guided therapy.
Yeah, something like that. And I know a woman who had brain cancer and she took that over because she couldn't do her nursing anymore.
Yeah.
And there was a man that was basically giving up.
Yeah.
But then when he went to that, because it was power of the mind,
Absolutely.
that he actually turned around. That actually, that's what it is.
And when you feel better, you do better. When you feel like you're able to do things because you're pain-free or you feel more like yourself, you're going to be able to participate more in your life. People have they have very concrete ideas of how they want to live. We just have to ask people about them and then respect that and try to help people to keep their goals.
Right.
So
We had put my sister in palliative care, and it was so much, as you said, easier, her thinking that she was not in hospice.
right, it's
Which,
like
I mean, we put her right in the next day, she passed away, but she
Yeah.
had a good day.
right, right.
know?
But I can't tell you how many docs that our goal, our only responsibility as healthcare providers is to give information, help guide you, tell you the good, the bad, the ugly, and not not give you false hope, not if the hope isn't there, but to be honest and to provide information and to make sure that you make your own decisions for yourself. We have no right to say what's good for you. You are the only one to say what's good for you. And as healthcare professionals, like I said, we have to, even if it's not what we would choose for ourselves or our family, we have to respect the decision and support you. And if something is going on that, if gears change and then, you want to change your focus, we have to support that.
Sorry. When I was talking to hospice here, I said, can we refer someone to palliative care on an outpatient basis? Is that going to be the way for the future, though? Because I think it's so important.
Yes, and other facilities, even though they're palliative, they have very active palliative care services. Those nurse practitioners go to the homes. They will come if people, for instance, are getting chemo, the day that they come for infusions. They'll sit and talk with them about goals during their infusion. Whatever is most convenient for the patient, whatever is the most, I did clinicals and going out to a house at 8 o'clock at night to sit with a person and make sure that their goals were met, that they were comfortable with how things were going, that their symptoms were controlled, that they were having the best possible life that they can have. And go into somebody's house and being able to see what's going on there, seeing dynamics, talking to children of it's like I said, it's really a holistic approach, and it's not just because most people don't want to die in the hospital. They want to die at home. They want to die comfortable. They want to die in familiar surroundings. So really, it is more of a not a hospital thing, but an outpatient thing, if you will. Because that's where people are comfortable.
I have one question, but this has to do with hospice. Would you happen to know the answer? Maybe I don't know.
Probably, we kind of,
Well, you know what happened, hospice couldn't make it today, so I have a few slides talking about hospice.
Okay, well, this is like a more, I guess, I don't know if I would call it a personal or what. I had a problem with one thing, it had nothing to do with the hospice here, okay? My husband was an organ donor. Nobody knew the answer.
I don't know.
with what?
With whether, who do we contact since he is home in hospice? Can he still be, since he's a cancer patient? You know, nobody knew an answer.
New Jersey Sharing Network, which is who, through New Jersey, who we contact. Typically, because it's a timing thing. You know, the most common for organ donation is, or I shouldn't say most common, but the most recognized is if somebody's brain dead. But that's most times, you know, people don't become brain dead. They die afterwards. There's a time constraint, meaning that certain organs aren't able to be transplanted after a certain amount of time. But I know like eyes, cornea, long bone, cartilage, things like that there's a longer lifespan, if you will. So it depends on the organ.
Nobody knew the answer. I'm
There's-
like, do you take them back to the hospital?
Do you have a plan?
Well, yes, and they were told this up front, and he was unconscious for what, a week and a half? And nobody could answer our question.
Did anyone call the sharing?
I was going to say that would have been the next, because
I
the New
have no
Jersey-
idea. They sent us to the funeral director. The funeral director's like, I don't know.
Well, you know what I think it is? It's such, a sharing network is such a hospital-driven program
Right.
because when you are an organ donor and your family member is brain dead, that person is usually supported on life support, and we're perfusing the body system.
Right, and there's triggers. When somebody's ill, there's triggers that the hospital staff recognize, and they actually, because by law, you have to call the sharing network for potential organ donation. They come out, they evaluate whether or not it's appropriate.
Right.
And actually in that situation, if you were given the number for New Jersey Sharing Network, it's a telephone call. They'll ask you questions about the underlying illness, and they could tell you right over the phone whether or not he would have been a donor, an appropriate donor or not.
We had it hanging by the bed, and when we called them, they didn't know.
Yeah.
They didn't know
Yeah,
because
that's
he
a
was
shame.
a
Because of him
cancer
being
patient.
home on hospice,
Yeah.
and he
Yeah,
had,
I think it's hard because I'm just
brain
thinking
cancer,
harvesting
but-
wise, you know. I even for skin and all that.
Yeah.
but then
for
that's
corneas,
what,
I
you know,
know,
we figured
I-
even for this eye, for, you know,
But
eye
even-
donation
yeah.
or whatever,
Right, but
because he
it's,
wanted to be able to be a donator so bad.
And like I said, at this point, if it would have been to even get him back to the hospital so that he would be able to do this. that
but
would
even,
be an option.
and unfortunately, you know, because New Jersey Sharing Network is really wonderful in that respect, that they would have provided, if it was appropriate, they probably would have provided services to get him to wherever he needed to be to donate.
Exactly.
Yeah, because they are, yeah.
I'll email the girl that I have,
Just
Just
for
for
future,
future.
for
Sure.
other people.
because there might be.
Because like I said, the hospice didn't know, and I do remember them giving a number and we called that.
Yeah.
And they didn't know
I know
because
that.
of him being home in hospice and
Yeah.
cancer. And, because I didn't even know if you could harvest with being a cancer patient.
It depends. I mean, organs, not, because usually a cancer diagnosis, if they have a history of cancer, a lot of times they'll tell you no. But I think that's also for organ. But like I said, one person can potentially save the lives of things like 50
That's what I'm
people.
saying, like he could be
Because he
walking
didn't even
around
go
and
for
stuff.
treatment.
Right,
Yeah.
because it's not even, there's so much between skin, cartilage, cornea, bone, all that can be harvested and
He
to
was
help save
primary
somebody's life.
brain tumor and no treatment
No
outside of
treatment.
surgery.
Yeah, and actually, and really, that's
To me, it was
it's
the
a
perfect
shame.
candidate.
Absolutely.
I'm sorry.
Yeah,
I
not
don't
to
mean
sound harsh,
quote.
exactly,
Yes.
not to say, but no, I agree, because it's not a metastatic disease. It's not.
Exactly.
Yeah, so it's unfortunate that nobody had that
But
answer for you.
sometimes, again, and you mentioned the word, brain cancer or brain tumor and everything, everybody almost thinks it's a like we're gonna catch it from somebody,
Right, sorry.
They think it's,
That's a good question, though, and I'll pose it.
It was something that really bothered me, and
It was
I mean, it's over a year now, it
was
still bothers me.
Yeah.
You want to find whose neck to grab and shake a boo.
Yeah, well, it should be for some.
Because it was a wish.
Yes.
Right.
Absolutely.
And again, going along with your life, how you want to live your life.
Right,
You want to
exactly.
be able to, that's something
That
that
was very
goes
important
along,
to him.
absolutely,
That was something he
with
wanted.
your quality of life and what you feel you've contributed to this earth we live
Exactly.
on. Absolutely.
There's no way they get the
Something that he wished, to have fulfilled. And because nobody had an answer.
Yeah,
It
and
can
like I
be
said,
fulfilled.
it's unfortunate, and it's surprising actually as well, because, and
But I
again,
do remember them giving a number, because it was timing about the deadline, I remember Jewel called.
Yeah,
And
so
nobody
we didn't get
knew.
it, yeah, we didn't get anywhere with that was the question. So it's like everybody's, good question.
Yeah,
Yeah.
everything.
but nobody provided an answer.
Exactly.
So glad you asked
The
it.
question of the year is like,
Right.
you know, we'll get back to you.
Yeah,
Exactly.
Sad. Very
it
sad.
is, absolutely.
I was saying, talking about sharing, I have to share about my friend who's been on dialysis for 30 years and he just got a kidney, and they said it's a perfect match. And they said it's like 2 and 200. Get that perfect match. He's now peeing in a toilet.
It's on there.
And that's exactly what I mean.
Yeah, no,
It-
it was the best thing. And
Yeah.
I'm going to have to leave for just a second. But what I want to ask you, can you come to the support group
We were
meeting
just
sometime?
Absolutely.
Because I think that misconception of what palliative care,
And it-
and I tried to mention it in my group, that was just with me, is so important.
I have, but, and again, there's so much, even with, because I can't tell you how many physicians, that we've offered surgery for, and the physician is, no, they're too old, it's not right, it's not appropriate, and I'll say to them, I said, and that's fine, absolutely, whatever you want, and it was really the primary physician who was the driving force about with the family's decision of not pursuing any surgical treatment. And I said to the physician, I said, so now your responsibility is to control symptoms when symptoms get bad. Because what's going to happen is all those fears sit in. She's going to get confused. She's going to get combative. She's going to have problems. They're going to panic. You don't want her treated. She's going to end up in the intensive care unit on a ventilator, having CPR done, which is not what you want. So you need to address that now. You control symptoms, you make people comfortable, you make them comfortable with their decisions as well. These decisions, are so difficult for families, and they second guess every decision that they make. So when you see your loved ones suffering or going through something and they're not themselves, you're going to second guess every decision that you made, and you can't go back on that. You can't, no matter how much somebody can tell you, oh, coulda, shoulda, woulda, don't worry about it. Right. It's still, it's easy for healthcare professionals. I always say, we're not spending Christmas dinner with you after they leave the hospital. Right. We're not going to your house. We're not dealing with the aftermath. And again, if we can provide the comfort to the families, knowing that, and to the patient, and
Some
to
answers.
let the patient know, and let the patient express to their families that, you know what, I'm comfortable, I'm happy, I'm not, so it helps.
That way they're not at home on Google trying
Right.
to ask, so everybody has 5 million questions.
Internet doctor.
Yeah, yeah, but it's true,
Okay.
so,
No, but that's what happens,
yeah.
I sent it to my list. Sorry.
Do you want me to speak for you? Do you have, I can read your slides?
But you just-
I
Do
mean,
you have questions about
I was gonna, yeah, is there, and again, with palliative medicine, like I said, it can be a transition to hospice. The palliative care team doesn't leave you, they're incorporated into the hospice approach.
Just like how
So-
important for support, she knows with doing the support,
Yeah,
group, how
yeah. Because there's so many, you don't know where to go. It's not like, everybody on your block is going through the same thing that you're going through. Yeah.
she only has 20 ounces on her block,
We
but.
have 8 deaths already in the past 10 years.
Yeah,
Oh,
spouses,
my
young
goodness.
Oh
spouses.
my goodness, yeah,
So it's not looking good on her block.
yeah. Do you have a tight group of?
No.
No.
It's not even.
No, I did go to a support group last year, which was very, very nice, because it was a small group of maybe 6, and it was all women who had lost their spouse.
Right.
Now, I decided to go back again this year because I wanted to see how much I've improved
Right.
throughout the year. And it's a totally different group. There's more members. It's people who have lost children, people who have lost spouses. So I'm seeing so much different.
Yeah.
And it was also something that I was thinking of getting into with children.
To do counseling? You mean
To
like
do
a support
counseling,
group?
yes. And I figured, well, the only way I'm gonna learn is by getting the feel of everything.
Yeah.
And it really comes down to communication. If you ask, people will tell you. If you don't ask, and if you're not open to, if people don't feel open that they can talk to you, you're not going to get the answers. But it's an uncomfortable conversation to have. Are you depressed?
elephant in
Like
the
you know,
room.
but it's true. It's
Yes.
true. And sometimes all it has to be is, how do you feel? How are you dealing with everything? This must be hard for you. And again, as long as you can get that a little bit of empathy, people will talk if you ask. And just the same as how they want to be treated, how medical decisions, people will tell you, do not do this, 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 and this. So, but you have to ask. If you don't ask, they're not going to tell you.
Exactly, and it's a
So,
lot of times it's things
right.
that they don't want to talk about.
And I've had patients, families tell me, you'll think I'm a really bad person if I don't do this, this, and that. I said, who am I to judge you? And how, I don't know your mom. I don't know how she lived. I don't know her personality. What do you care what I think anyway? Nobody else cares what I think. It's not about us, and it's not about the healthcare. It's about you and your family and what is appropriate for you. So, yep. I think like I said, you have to the control, and a lot of times, well, my doctor said that I should.
Do you want to?
Exactly. So, okay. So,
Insurance will work with you?
yes,
And-
actually, with palliative medicine, with hospice, absolutely, it is provided. I know with hospice, they provide an aide to come to the house to help with washing and clothing and help with meals. It is absolutely covered with insurance.
Right to the insurance company, yes,
It's part of care, and it's just like as if you would go to schedule any other, have any other test, or any other treatment. Hospice and palliative care is covered by insurance.
Is there a waiting period before you go on hospice care? Insurance might say, let's wait 60 days or 6 months or something like that.
With hospice, they term appropriateness for hospice is a 3-month. They expect you to not live beyond that 3 months. It's 6 months? 6 months. But people who go into hospice live for a year. But it's not like they say, 6 months, you're done.
Take you off.
Yeah,
But they might want to reevaluate you.
right.
So, like if you're doing really well, like we had somebody that was, a year and a half out, and they called me and said, can we do another scan on her? Like, because she's a year and a half out and we don't know, you know. It's not uncommon that they would take you off. We had a fight with somebody who they said was patient, should not be on hospice. And he didn't want treatment anymore. He had a GBM and he needed symptom management. And we had everything. And the hospice, which I'll never use them again, stopped.
Yeah.
And he ended up having to go into the hospital because his wife couldn't take care of him at home. She didn't have anybody to call. And he died in the hospital. And because they took away that.
Yeah.
So, and that's not a normal case.
Right.
It's usually a very comfortable transition. But I think just focusing what Beth said too is, palliative care gives you that transition to knowing what you want, and that's where your healthcare power of attorney, having a power of attorney, even if you're going through surgery and you can't make decisions for yourself, having someone be able to make them for you, you know, what you want, so vocalizing what your needs and your wants are. There's something called the conversation, which is, I just talked about it in my last, so knowing, having advanced directive, what your wishes are, a living will, it's a document that you state all of this in, whether, and you know, you've dealt with it more in the ICU, and saying, you know, I don't want to be intubated, and when you come into intensive care, they do a DNR, right, on everybody.
No, well, unfortunately, because we have to, CPR is the only thing that you have to do to everybody unless they tell you you can't do that to me. So again, if the question's not asked, then it's assumed. So we do ask when they come to the critical care unit. It's usually the nurse because, and I've had more than one doctor tell me, do not discuss that now. Do not, and really that's the worst time to discuss what you want, is when you're under incredible amount of stress, you're critically ill, you can't breathe. Guess what? I can't breathe right now, so you know what? For you to tell me, ask me how I want, what do you mean? Like, make the breathing better. Right. Well, this tube can help you make the breathing better. Well, you know, all right, well, if you're telling me that that's the only thing that's going to make me feel better, although, you know, when I was feeling well, I said, you know what, no way are you putting me on a ventilator. But now that's my only option. But again, if you control symptoms, and if you know, if you have a clear understanding, if you have a good mouthpiece, you have somebody who is going to fight for you, and because we can be selfish. It's very easy to say, yeah, I know what they wanted, but I still want them here. Nobody wants their family member gone. Nobody wants their loved one gone. And it's easy to be selfish, but you have to have that person who's going to say, no, this is what we need to do. So, and this is what they don't want. So what can we do to get them comfortable in the meantime and still maintain their goals and still aggressively treat?
You had to go through that selfishness once.
Yeah.
Just one time.
Yeah.
I know. There's something called the Conversation Project, and it's a piece that actually lays it all out for you, having that conversation with a family member. And in that, you can say what your wants, your needs, and how much treatment do you want. So anybody, like I bruised that with my parents, and I said, this is where I want to be if something happens to me. This is what I want. And my mom will not be my medical proxy because she will keep me alive no matter what. But my brother, who understands, this was before I was married, I had it. You know, now my husband and I, we've not formally written anything out, but we've talked about it. And his mom's a doctor, so she's given her whole body to science, you know, so we kind of know her feelings. I think it's very important, so this conversationproject.org puts it into paper. And you can print it and have the discussion and talk about what your plan would be in any situation, and what your definition of quality of life, and I think you mentioned that.
Yep.
It's what you're comfortable with. And I spoke about it earlier, that one person can be in a wheelchair with aphasia, not being able to speak, but that's what they want. They want to be here no matter what, and that's okay. So we're going to do anything that treatment-wise if we feel it's appropriate. So, I mean, those kind of conversations. The differences that come is between palliative care and hospice, and maybe you could just
Sure.
kind of go through it. I mean, there's not a lot, but there are some.
Okay, so with the comfort care, the difference is with palliative care, it's comfort care for serious illness that starts at the beginning of a diagnosis. With hospice, the comfort care it's like that transition, like we said, over towards the end of the life, usually with a 6 month, usually lasts about 6 months. Palliative care may be covered by insurance, and I think that's actually turning around more, that more insurance companies are recognizing palliative care and covering it more. But with hospice, most insurance companies have plans and they have a hospice benefit, and it is covered by Medicare. And again, as I said, with palliative care, you can continue treatment for a cure, for curative care. With hospice, it's that there is no active curative care, it's only comfort care. With palliative care, services are provided by hospitals, hospices, nursing facilities, healthcare clinics. With hospice, services are provided at home, assisted livings, nursing homes, hospitals.
And that's kind of changing.
Yeah, I was going to say that's,
Yeah.
and like I said, the one place I did my rotation with for my master's with palliative care, it was focused in the hospital, but you didn't have to be a hospital patient from there. You didn't have to. That's not the first time we met you was in the hospital room. We can meet you on an outpatient basis, and then they go out to the homes as well.
Who decides whether I'm ready for hospice care or not, the doctor or
Yeah.
Right, both.
the doctor?
I mean, some patients will say, I'm done with treatment, I don't want anything else. And they've been stable for years. So hospice, so we might just follow them every 2 months. But if they're not gonna do any care, then, but they're stable, but with just the diagnosis of, say, a GBM, we can put somebody on a hospice care if they needed it. Sometimes what we do is in that situation where someone doesn't want care, then what we would do is maybe give them a referral to hospice so they make the connection and they talk and meet. And then after that, then it's their option to contact when they're starting to decline and feel the need. Sometimes we have and Dr. Landolfi, who I work with, is very appropriately aggressive. Someone in your shoes, we would encourage treatment. You know, you're talking, you're physically interactive. There's options out there. We're going to encourage treatment, you know. And we had a gentleman who had a metastatic disease, but his son was getting married. So he wanted to continue care to see his son get married. He had a cancer elsewhere in his body that went to the brain. And we did just that. So it's a conversation between the doctor of what your quality of life and what you expect. If you don't want to be hemiplegic and that's what the tumor is going to do to you, and that to you isn't quality of life even, then we'll work that through together as a team. And we're members of a team. You're the captain, we're going to help guide them for you.
But there's no, maybe you answered the hospice waiting period.
There's no wait. When there's nothing else to do and this tumor keeps growing, and you've exhausted all treatments, then there's an endpoint where we say, we can't do anything else. And then we'll sit and talk about it. But I think that's where you need to let your physician know too, is what's your endpoint? Like, what is your vision of quality of life? What do you want out of treatment? And it's thinking to have. And I think that some of the changes that, like clinical trials and stuff, that's where palliative, not clinical trials, I'm sorry, where symptom management comes into play. Because even the general population, you get a UTI, a urinary tract infection, it's going to affect you guys differently than it's going to affect us. A common cold is going to bring you down. Any deficit that you have it's gonna be worse. We've had people that were cognitively not functioning, that when we treated the UTI, they got better. But you go into a family practice who's not brain tumor savvy, they see that they want to initiate hospice.
Right.
It might not be time for you. So that's where palliative care and symptom management really comes into play. So they work hand in hand. And that's where your neuro-oncologist is going to help you, guide you. Let's get through this medical issue. Let's see how you do. And then let's go from there.
The healthcare proxy, if you have one in New York, you also need one in New Jersey.
No. Just make a copy, and the biggest thing I say is, and you've probably seen this too, my family member has a will or a living will, but we don't have a copy. We can't do anything. You know, we have to have that copy.
And make sure your docs have that information, because even the hospital, if you come into the hospital, oh, it's on record. It's really hard to get that out of record. So if you're the doc who you see on a normal basis, who you see in the office, give them a copy of it. Make it part of that record, because if that doc is going to be the one to meet you in the hospital if something, if you deteriorate, at least they have it and they know. And that conversation also, the conversation that you have with your family about, what's acceptable, what's not, with the conversation you have with the healthcare proxy, you should also, that the physician needs to know what you want for yourself as well.
Does it work if you carry it with you?
It does.
Yeah. Because like right now, I'm in a situation where it's me.
Yeah.
I have no children, it's me. And I volunteer at the hospital, and it was brought to my attention, which is something I never thought about up until a month ago.
Yeah.
My director said to me, I have to update your files.
Yeah.
Who do you want me to put down as your contact? And I'm like, wow, I'm totally screwed. Because nobody answers the phone that I know.
Yeah.
So, they wouldn't answer the phone.
Right.
And it'd be like days later, I'd be laying there with a ventilator, and I don't want that.
Yeah.
So is it appropriate, like not appropriate, but if you had a copy of it on you, would they accept that?
Absolutely.
Okay.
Absolutely.
Does it have to be like notarized or anything, or just your?
No, and that's a misconception too about advance directives or living wills. You don't have to get it done by a lawyer.
Okay.
As if it should be, it has to be notarized, I believe. No, it doesn't. It can be. Yeah, I was going to say, they don't. And it doesn't have to be a formal, like, it's not like you have to spend $500 at a lawyer to have the lawyer draw up your advance directives. It doesn't have to be that way.
So I could just make copies and.
Even if you had said to,
Because the physicians, like we're down in Cape Cod. Our physicians don't even go to hospitals.
Right, I was going to say they have a lot of hospitalists.
Hospitalists.
Yeah, the hospitalists down there. Yeah.
So they don't even contact your doctor.
Right. As long as you know, and if you come in and you're able to speak for yourself, it's at that time that you say, this is the person who you contact, this is my healthcare proxy. Now, if you're saying it directly, then we write that down and we make note of that. If you're not able to tell us, and then you have 10 people coming in, and your neighbor says, "Oh, she said that I said that that I'm the one that's going to talk to her." Well, we don't believe that. There is a legal way. It goes by next of kin. The first thing is spouse. If you don't have a spouse, if you weren't married, parents. If your parents aren't there, then it's the firstborn child. If that firstborn, and really, if there's somebody to speak with, to speak for you. Whether there's 5 people in your family or 1 person, it's usually a family decision. Usually those decisions, even though it's 1 person who has the power of attorney, those discussions are usually a unified decision among the family.
If they text them.
Yeah, I was going to say
But
that.
she wants to make sure, because I have the texts of all her relatives.
because
she doesn't have a way to get in touch
They
with
don't, and as I said to her, I go, I'm just gonna have to put you down. Because you're the only one that answers the phone.
Yes.
Newsy.
Yeah.
The only one has the power that.
Yeah.
Because I know they wouldn't.
Yeah.
And that's why I'm asking, like, if it's something that you should carry.
So
You
she
can,
would have to have
absolutely.
something like a bracelet type thing to.
And they do. They have these. I
Yeah.
had a patient that had this bracelet that had a chip, just like a flash drive.
Right.
And it was his complete medical history, all the
Really?
contact information,
Really?
every medication that he was on,
And
and
how
it's
did
a
you know that
bracelet.
it was
He got it
that?
through and it said it was like a medical
Medical
alert
alert.
bracelet,
Uh-huh.
and it had a flash drive. And he said every time he goes to the pharmacy updates if he's got a new medication. They plug it in, they update his
No
medication,
kidding.
and it's always on his person.
Avid bikers and, you
Yeah.
know, people who exercise, a lot of people wear those
Yeah.
that have medical stuff.
Oh, that's
No kidding.
interesting.
And it looks like you can see like it's something like that?
Yeah,
Well,
it looks
it's
like
what you see,
like
like
a
a
like a
USB
medical alert.
thing.
It'll have like the medical alert on
Right.
it, and it's a flash drive,
Oh,
and
no
it's
kidding.
just a regular
There's-
bracelet.
There's another one.
Google it.
I will.
There's
I
another
will.
one that it's just a number and it tells you the website, and when you log into the
It
website,
has all the.
you put your
Right.
ID, which is on the band. So people and ambulance drivers have been able to, you know,
Even the ambulance drivers have the
Right.
ability.
Oh, okay.
Because she only has a lot of bracelets on her. She had another one.
We're done.
done.
Okay.
Okay.
Oh, I just want to say one thing about hospice. When they were putting my husband in hospice, I wanted to make sure everything was prepared for him when he got home. So I had said to the people that were there signing up, I said, do the sheets come with the bed? And the guy looked at me and he goes, I have no idea. Not a clue. So I called up my nephew immediately and I
Yeah.
said, run to the store and get sheets, put them on that bed. Right?
Yeah, because
Yeah.
it'll be in the extra length.
Yeah, I was gonna say it's a different. Yeah, or if you have a king size bed and that's a twin,
First
it's
of all,
a
they were just transporting him and they were just gonna,
yep.
you know.
Put him
and
into a bed.
Yeah, they had the bed
Yeah.
there and everything, and then we were up at Cooper, and then going down, and then
Yeah.
you had to hurry up and do that to make sure you keep
Wow.
all the sheets in the bed.
Yeah,
So that's a question, and I called up the hospice place and I told them,
yeah.
you know, you don't
But
do
these are,
sheets.
but these are things too that people don't necessarily know. So it's important to get feedback from you
Well, that's
guys.
what the guy said.
Thank you.
You're very
Thank
welcome.
you.
Thank you very much.
You're very welcome.